It's all about knowing when to not intubate your patients, okay? Let's start off with a case presentation here. You have a 70-year-old female, calls 911 for shortness of breath. Your initial vitals, you got a heart rate of 128, respirations are 28, blood pressure is 80/45, oxygen sats are 75% on room air. Patient is lethargic, responds to painful stimuli. You immediately, you start oxygenating them, you put them on 100% FiO2 via the non-rebreather, okay? You start an IV access, you start an IV fluid bolus. A few minutes later, you reassess, your heart rate is 123, respirations are 29, your blood pressure is 85/53, and your sats have marginally improved, they're 80% now. You got a 20-25 minute transport ahead of you. What are you going to do? Okay, so this is a very sick patient here, right? This is a sick patient on multiple levels here. Things can go bad very quickly on this kind of a patient. So when we talk about airway, a lot of times we talk about the anatomically difficult airway, okay? And these are pretty easy to spot, right? You got a patient that looks something like this, you might have a difficult airway here, okay, from an anatomical standpoint. So, there's lots of mnemonics, scoring systems that kind of help guide you to know, hey, this might be a difficult airway here. Maybe I shouldn't be going and trying to intubate this patient in the back of the box. Maybe I should, optimize this patient, put in a supraglottic airway, try to oxygenate them without trying to intubate them and get them to a higher level of care. So, the anatomical difficult airway, very easy to identify, okay? However, when you talk about the physiologically difficult airway, this is a whole nother ballgame, okay? This is referring to derangements in the patient's physiological status that if you try to intubate these patients, you could potentially cause them to deteriorate or possibly kill them, okay? So these are the killers. The physiological derangements are the things that will cause your patient to arrest on you when you go in to try to intubate them. So you need to stabilize these derangements before you even think about trying to intubate these patients, okay? So these are the 4 things that I'm going to talk about today. Of course, you can expand this, but these are kind of the main things right here that are very dangerous, and they're very easy to spot, okay? So you got hypoxemia, hypotension, severe metabolic acidosis, right ventricular failure, and of course you got Ric Flair in the WWE. So, so the first one we're going to talk about here is hypoxemia. Hypoxemia, of course, it's a very dangerous intubation when you got a patient that's not saturated very well. Okay, how many people have had a patient who's satting 70%? You're trying to bag them up. It's kind of an anxiety-provoking situation, right? I mean, you're working pretty hard. You're worried, man, I hope this O2 sat comes up. What are you going to do here, right? These folks are very dangerous to intubate because, there's a common misconception that we can all sometimes get. All right, I'm bagging this patient. I got an OPA. I got an NPA in. Sats aren't coming up. I just need to go ahead and put a tube in. I know I can get a tube in like 10 seconds. I just need to put a tube in, and then I can get this patient properly ventilated and get that sat up to 100%, okay? But that's a very terrible misconception, and that's something that we don't need to be doing, okay? In these hypoxic patients, you've got to make sure that you're pre-oxygenating them, okay? Extremely important. If you don't have an O2 sat above 95%, you better not put a laryngoscope in that patient's mouth, okay? That might sound extreme, but I'm going to show you why. You need to pre-oxygenate these folks. You get them up to 100%, the longer you have them pre-oxygenated at 100%, the longer your apnea time is going to be, okay? The longer they will hold their sats once you push the RSI drugs. They'll be able to keep their sats up a lot longer. It gives you a lot more time to go in and look at these patients, right? You want to pre-oxygenate for at least 3 to 5 minutes. You want to wash out all the nitrogen in their lungs, okay? So even if you get them up to 100% immediately, let them stay on 100% for several minutes and completely wash out the nitrogen that's in their lungs and get a reservoir of oxygen in their lungs, okay? And that helps them stay saturated for a lot longer. You can also sit the patient up, for 20, 25 degrees in the stretcher, okay? What that does is it helps promote their lungs to fully expand, and it prevents atelectasis in the posterior part of their lungs when they're lying flat, okay? The critically ill, obese patients and children, they're going to desaturate extremely quickly on you, so these are even harder patients to intubate, okay? So let's take a look at this graph here, okay? This is a very important graph. I want this to be burned into all of your memories as far as when you go to intubate these patients, okay? So first, can everybody see this okay? I know it's kind of washed out, but let's take a look at this line right here. The normal 70-kilogram adult. Has anybody seen one of those before? I know they exist, but I haven't seen one in my practice yet. But the normal 70-kilogram adult, if you look at them, look how long they maintain their O2 sat for, okay? You bag them up, let's say 99%, hundreds all the way up here. But if you got them at 99%, they're able to maintain that saturation for a pretty long time, almost 7 minutes, okay? They're able to maintain for almost 7 minutes, but then after that 7-minute mark, look what happens. They drop off extremely quickly, right? And if you look at the O2 sat, that's about 97, maybe 96% right there. Okay, 95 is right here. At 96%, if you don't have a tube in that patient, they're going to drop off on you extremely quickly. Okay, now that's a normal patient. Okay, a healthy person. You shouldn't be intubating a normal, healthy person anyway, right? So let's take a look at a patient that might be more applicable to us. The obese, 127-kilogram adult. Okay, and actually, we need a third line in here. One that combines the moderately ill adult and the obese adult, right? Most of our patients, we're in East Texas. Most of these folks are overweight, obese, okay? And look how long they're able to hold their sats up. Less than 2 minutes before they quickly drop off on you. 2 minutes, less than 2 minutes. You could say a minute and a half, okay? So look what happens. You pre-oxygenate them up to 100%. You've got a minute and a half before they're going to drop off extremely quickly, okay? And that O2 sat is only 97%. Okay? You ever thought, yeah, 97%, I need to pull out and start bagging again? But that's what you're looking at. You hit 97%, you better start thinking about pulling out and starting to rebag them, because they're about to drop on you like a rock. Look at 95%. When you're at 95%, you're already on the steep part of that curve, and you're going to drop extremely quickly. That's what I'm telling you. When look at all these graphs right here. At 95%, you're already on the steep part of that drop-off. That patient's O2 sats are going to start dropping on you extremely quickly once you get to 95%. So let's take a look, okay? You got this obese patient right here. Let's say you're trying to intubate them, okay? And you're like, oh, just give me a little bit more time, give me a little bit more time. You're at 95%. Look what happens here, okay? In less than a minute, you're down to 90%, okay? This is at about, what, 2 minutes, maybe 20 seconds? So let's look what happens in 1 minute. In a minute, you're down to 80%. In a minute, well, here's a full minute mark right here. You're already down to 75% in 1 minute. Okay, so and your O2 sats were 95%. Well, you thought you had time, right? You didn't. So if you don't have that O2 sat above 95%, don't think that you're going to get in there. Oh, I'll get the tube in 10 seconds really quickly, and I'll ventilate them back up to 100%. No, you're not. That's not going to happen, because you're going to be doing chest compressions on this patient. Okay. And then you're going to be coming into 116 to change your pants, because Dr. Desai told you not to intubate this patient if the sats are lower than 95%. Okay? So I want you to remember this. Look at 95% and look where you are on these curves. On every single one of these patients, even the normal healthy adult, you're on the steep side of this slope where you've got about 10 seconds before this patient's O2 sats are going to tank like a rock. Okay? And what happens with hypoxic patients? They arrest on you, okay? So remember that. Another thing, I've had a lot of folks talking about RSI in children, okay? Look at kids. Kids are almost as bad as an obese adult. Look how quickly they drop off, okay? So you can't really play around with these patients. You've got to be extremely vigilant, and you've got to be extremely careful with these folks. 95% sounds like a great O2 sat, but you're in a very dangerous place if you've already dropped down to 95% while you're trying to intubate a patient, or you're thinking about intubating a patient, okay? So what do you do about the hypoxia? Okay, well, we have our standard non-rebreather, right? You put them on 100% FiO2. So here's the thing about non-rebreather. It's good, but you don't really get a really good seal with a non-rebreather mask, right? They're kind of flimsy. So you're actually only delivering more like 60 to 70% FiO2 when you have them on 100% non-rebreather, okay? So if that's not working, okay, you can always bag ventilate, your basics, okay? Be good with your basics. Be proficient with your basics, and you can do a lot with just your basics that you'll help the patient and you won't necessarily kill them, right? The other thing you can do, non-invasive positive pressure ventilation. So the CPAP mask, okay? CPAP mask helps improve oxygenation in obese patients, okay? It helps push air into their lungs, and in these folks that are obese, it's going to help open up their lungs, helps recruit alveoli, and now you get better oxygen exchange. You'll see their O2 sats start coming up, okay? If you're using it to pre-oxygenate patients before intubation, I know a lot of times there's contraindications. If you got a lethargic patient, someone that's not responding, you don't necessarily want to put them on a CPAP, but remember, we're not putting them on a CPAP and leaving them on it. We're trying to do it as a pre-oxygenation tool. So sometimes that contraindication may not apply. You're just trying to use it to get their O2 sats up above to 100%, and then you're going to intubate them. You're not just going to leave them on it while they're unresponsive and lethargic, okay? The other thing, how many oxygen sources do we have in our ambulances? Three, right? So use them. Hook the patient up to a nasal cannula, turn it high flow 15 liters, and put them on a nasal cannula while you're doing all this other stuff. Who says you can't have more than one oxygen source on the patient? Okay? This patient is hypoxic, 75% O2 sats. This patient needs oxygen. Put the nasal cannula on them, and that's passive oxygen. And then you can bag them, you can put them on the CPAP, you can put on a non-rebreather, you can do I-gel, okay? So in some patients, due to anatomical reasons, they may not be able to get a good seal on the CPAP mask, right? Whether, they're edentulous or they don't have a chin or whatever reason, CPAP mask may not work very well if you can't get a good seal on them. Well, in these patients, consider putting in the I-gel and ventilate them till you get your oxygen sats where you need them, okay? This is something that I know currently may not be part of our protocol, but things are being reviewed. If you have a patient that's not tolerating I-gel, consider giving them a little ketamine, okay? To kind of give them what's called a delayed sequence intubation. That's something. That's another topic to talk about. But if they're having a hard time with the I-gel, you give them a little ketamine, and now they're able to tolerate the I-gel a lot better. You don't have to end up tubing this patient and killing them, and you're able to oxygenate them. The other thing, put the NG tube in. The I-gel has an NG tube port. Use it. Dropping an NG tube is going to decompress the patient's stomach. It's going to allow better expansion of the lungs. And if the patient is gagging or they've got a stomach full of fluid or whatever, you're going to suck all that stuff out, and now you're not going to be dealing with all this emesis coming up in your oral cavity. Okay, so consider putting in the NG tube, even if they're not throwing up. Put it in because you need to decompress their abdominal cavity so you can ventilate better. Okay, the other thing is apneic oxygenation. Has anybody ever heard of apneic oxygenation? That's basically the concept that I was referring to. Putting the nasal cannula on these people even if they're not breathing in through their nose. So when a patient is apneic, the lungs continue to absorb oxygen at a rate of 250 milliliters per minute. Okay? So what this is doing is it's creating a pressure gradient that's going to help suck oxygen into the lungs from the oropharynx. So if you've got this nasal cannula going at 15 liters a minute, even though they may not be actively taking a breath, that oxygen is being forced into their oral cavity, and their lung is going to suck that oxygen down to the lungs. It's going to help keep their O2 sats up a lot longer when you do go to intubate. Okay? And the same thing, whether you're trying to pre-oxygenate them with the CPAP or you're trying to bag them or whatever, it's going to help get that oxygen sat up. So do it. It's hands off. You don't have to do anything. You put it on, you turn it on, and guess what? It continues to do work while you're getting ready to put the laryngoscope in and take a look. So everybody should be having 15 liters of nasal cannula going on them when you're trying to intubate them and you're having a hard time getting their sats up, okay? So the next thing we're going to talk about is hypotension, okay? Hypotension is a bad one as well. So hypotension during intubation is common in 25% of the patients, okay? After intubation, it's common in up to 30% that are critically ill. So if you got a patient that's hypotensive before you even start trying to intubate them, and then let's say you're lucky and you get them intubated, what's going to happen? They're going to be in a lot worse shape than they were when you started off, and now you're going to be chasing your tail trying to get this patient stabilized, okay? So when you try to intubate a hypotensive patient, you're increasing the risk that they're going to arrest on you. You're going to prolong their ICU stay, and it's shown to increase their hospital mortality, okay? So what do you do with these patients? Volume, okay? You need to resuscitate them, okay? IV fluids, get that blood pressure up, all right? A lot of these patients are so sick, you need to start some vasopressors on them, okay? Levofit is the preferred vasopressor of choice, okay? Anybody in here still think it's dopamine? Dopamine is not the one to go to, okay? There's certain cases where dopamine might be the right one, but in these critically sick patients, you need to be putting them on Levofit, okay? So just as you would pre-oxygenate a patient before you intubate them, you know, you get their oxygen levels up to 100%, you need to be priming their blood pressure just the same way to make sure that patient isn't going to arrest on you when you tube them and you drop their pressure down to 60s, okay? Shouldn't be tubing a unstable hemodynamic blood pressure, okay? And the last thing is the drugs that we intubate with, okay? A lot of these drugs can cause hypotension. So if you got a hypotensive patient, you want to use drugs that are going to be hemodynamically stable, ketamine, etomidate, okay? The third thing, acidosis, okay? You got an acidotic patient, you know, there's multiple reasons patients can be acidotic. DKA patients, probably one of the most common things, okay? I know we don't have the capability to check a blood gas from the back of an ambulance, but if you suspect a patient has DKA, you can suspect that they're acidotic, okay? If you got a patient that's overdosed on aspirin, they're gonna be acidotic. If you got a patient with ischemic gut or, you know, obvious ischemia to their legs, they're probably gonna have acidosis, okay? Patient that's, you know, got lactic acidosis due to sepsis or whatever, these are folks that are acidotic. These are dangerous people to intubate, okay? So what happens with these acidotic patients? So first of all, you know, we get ready to intubate patient, we give them medications to make them apneic, right? So they're not breathing anymore. The CO2 builds up, even though it's not for a very long period of time, but you get enough of a CO2 buildup, it further causes a drop in their pH, okay? The other thing, these patients are usually very tachypnic, right? They're breathing fast. We're talking 30, 40 times a minute. These DKA patients, you see them and they're moving, right? They're breathing 30, 40 times a minute because they're trying to blow this carbon dioxide off to compensate for the acidosis. So what do? We come in and we intubate them thinking, oh yeah, he's breathing too much. You intubate them, you put them on the vent. What's the rate that the ventilator goes up to? 18. 18? So guess what you just did? You just slowed that patient's breathing down so much, now their CO2 is going to build up, and you just made that pH go from 7.1 to 6.7. And what do acidotic patients do? They code, okay? They arrest on you. So you want to avoid intubating patients that are severely acidotic, okay? If you got this DKA patient and they're breathing really fast and they're getting tired, support them with non-invasive positive pressure ventilation until you're able to resuscitate them better and get that acidosis resolved. It's not going to happen in the back of an ambulance, but you know, just put them on the CPAP and help them breathe instead of trying to tube them because it's not going to go well. Okay. If intubation is necessary, and this is more for our ER folks, but if it is necessary, because our vent doesn't do this, but you want to put them on a vent mode that allows them to maintain their own minute ventilations, okay? Pressure support, pressure control. And that way they're able to continue their minute ventilations even though it's going to be extremely fast, okay? So the last one that we're going to talk about is right ventricular failure. Now this one is a tough one, okay? This is something that's, it's sometimes difficult to know, but there's a couple of things when you see right ventricular failure, what's going on. They're backing up fluids down to their lower extremities. They've got a history of heart failure. But right ventricular failure is very tricky because it's hard to treat it as well. So what happens in right ventricular failure? The heart is having a hard time pumping blood to the lungs, right? The right side of the heart pumps blood into the lungs. So when you have right ventricular heart failure, that means fluid is backing up into the lower extremities, into the rest of the body, okay? What happens when you intubate a patient and now you're giving them positive pressure ventilation? You increase the pressure inside of the lungs and inside of the chest. That blood that's coming from the venous side is going to have a much harder time making it to the right side of the heart, right? You're positive pressure ventilating these folks, so now you got increased pressure inside of your lungs. What happens? All the lung capillary beds start collapsing under this increased positive pressure, okay? So now the entire pulmonary vasculature is also being collapsed and has increased pressure. So now you got this weak right ventricle. You're not getting a lot of blood into it because the venous return's not making it, and it's having to pump against this very high pressure in the lung vasculature. Ultimately, it's going to lead to cardiovascular collapse. Okay? Do you guys understand what preload and afterload is? Does everybody know what preload, afterload means? Okay. So what do you do about this? This is very difficult, for pre-hospital, there's not a lot that you're going to be able to do with this. You got to be really careful with these patients. A cautious fluid bolus sometimes will help get enough venous return to their heart that'll kind of help them get more blood going into the lungs. Okay, and by cautious, I mean you want to give these folks small aliquots, 100 cc's at a time, 250 cc's at a time, and see if they respond. Some of these folks will actually respond to fluid, and you'll see their blood pressure improve, and you'll see them start circulating a little bit better. Okay, that's going to be hard, and that's going to be a really slow, very cautious process. But in the meantime, if you got somebody that's needing an airway, the main thing that you want to do with these folks, oxygenate. Okay, you want to do not try to mess with these people if their oxygen sats are not 100%, and you've not kept them at 100% for about 5 minutes, because these folks are going to desaturate extremely quickly on you. Okay, extremely quickly. The other thing we can do is consider an inotrope, levofed or dobutamine. I know we don't have dobutamine, but that's something else that might help with that right ventricle, try to get it pumping a little bit better, and that might help improve the patient's condition. But we got to work with what we have, right? Another thing, and this is kind of more on the hospital side, but one thing they can do to kind of help relieve some of the pulmonary hypertension is nitric oxide, your nitrates. But that's getting into pretty advanced stuff. So let's go back to our case that we started with. So, you had the patient on a non-rebreather, you started a fluid bolus, patient wasn't doing too good. So you put in an OPA or an NPA, and you started bagging the patient. And you got the O2 sat up to 95% now, okay? Patient starts waking up, and now they're responding. Okay, great. Now you put them on CPAP, brought their O2 sats up to 100%, okay? Voided intubation altogether, okay? Or patient did not arouse, so you put an I-gel in, you dropped an NG tube, decompressed their stomach, and now you didn't have red Kool-Aid vomit all over the back of the truck, okay? You were able to expand the lungs very good because your stomach was now decompressed, and you were able to bag the patient up to 100%. Just remember, your oxygen sats, it's going to take a little bit of time to get it up to 100% in these people. These folks are sick. They've probably been, 70% O2 sats for who knows how long before you got to them. You can't expect their O2 sat to just come up immediately. I think, when you have a patient that's hypoxic, it causes a lot of anxiety, and it makes us think, man, we need to do something immediately, and it sometimes can push us into the direction of intubating these patients when they're not ready for it, and makes us look bad, right? So you want to make sure, you know, I was talking to somebody, O2 sats are like the stock market. Anybody in here mess around with the stock market at all? Too much? So, you know, if for those who don't know, when you got money in the stock market, you know, in order for it to get some gains on it, it takes forever. But boy, when that stock market crashes, it just bottoms out on you like a tank. O2 sats are the same way. It takes forever to get them up from 75 up to 100%. But boy, you take that mask off for like 30 seconds and boom, you're down to 65 again. So just remember that, okay? Don't become impatient, okay? Be good with your technique. You can bag these people up to 100%, CPAP them, do what you gotta do. Put the nasal cannula on them, but don't make the mistake of thinking, man, his sats I got them up to 85%, it's not coming up anymore, let me just see if I can tube them, because just remember that table that I showed you, okay? They're gonna crash and burn on you. You put 2 IVs in, okay? You had one, you started a second one, you got 2 liters going in on them. You get to the ER and the sats are 100%, heart rate is down to 115 now, blood pressure is 101/65. They intubate the patient in the ER without complications. They don't code, they don't desat, they don't die, okay? And the physician commends you on the great job that you did on a very sick patient, and the foresight that you had in realizing, hey, you know what? Maybe I need to optimize this patient instead of just trying to force a tube into the patient. You did a really good job. Who's your medical director? He must be really good. I'm kidding. So keep a global view. This is going to be something you're going to hear me say a lot, okay? We need to keep a global view of what's going on with our patients, okay? Care of this patient does not end when you part ways with the patient, okay? You don't necessarily have to force a definitive treatment on a patient that's not ready for it, okay? You're putting the people at risk by doing this, and you know you're not doing yourself any favors. So it's better to start all the interventions to stabilize them, so when you do get to your final destination, guess what? Now they're able to complete the treatment that you started, and the patient has a much better outcome, right? The glory is all in the details, okay? Putting in place the appropriate interventions to stabilize and optimize the patient for the intubation, way more important and way more beneficial for the patient, and it assures that this patient's going to have a good outcome, right? There's nothing glorious about, oh yeah, I intubated this patient, but then you bring them in doing CPR on them. Defeat of the purpose right there, okay? So you're much better off starting all the fine-tuning and getting that patient to the right place. And hey, I got him here to you. Let's go ahead and let's finish this off now, okay? As far as the pre-hospitalists, all you guys are the most important people as far as treatment of these patients go. You're the first line, okay? You're the first line of treatment for all these folks. The rest of the treatment tree, the ER, ICU, cardiologist, nobody can do anything if you can't keep the patient alive and deliver them safely to the ER or to the ICU or wherever, right? So it's extremely important that we know what we're doing and we're doing things the right way, okay? Never harm the patient, okay? Keep the patient's best interest as priority number one at all times, always, okay? And the biggest thing, resuscitate before you intubate, okay? You got these sick people and it might be a trigger thought, man, this patient's gonna need to be intubated. Think about it. Think about it before you go down that road, okay? Lots of things you can do to make it a much safer process so you don't end up taking that patient in with chest compressions, okay? That's all I got. We have any questions? Yes, sir.
In the scenario you're talking about either putting in an OPA or putting in an iGel, I guess I'm under the assumption that the patient still has a gag reflex. How do you advocate getting past that? High dose ketamine disassociating those, or go ahead and start the RS arterialization and in order to facilitate those adjuncts?
So the question was, if you got a patient with a gag reflex, putting in an OPA or an I-gel in this patient, how do you get around that? Okay, so, and this is something that, we're going to work on. So you don't want to paralyze this patient, but you can give them, ketamine is very safe because, they're able to keep their respiratory status intact. It doesn't necessarily cause respiratory deterioration like some of our other sedatives do, but it'll help them tolerate a lot better so they're not gagging and choking on it, okay? So you don't want to paralyze them because, well, that's pretty much doing the same thing. You paralyze them, okay, you're going to have to do something about it. Yeah, you've already pulled the trigger. You can't take the bullet back now. So you don't want to paralyze them, but what you do is you give them a ketamine dose that helps dissociate to where they're able to tolerate the I-gel or the OPA placement, okay? Now, hopefully you don't want to do that to put an OPA. If you're going to do that, put the I-gel in,
Yeah, well, I mean, that's just a scenario. It
Right.
needs either or.
Yeah. Okay. What else? Any questions from the Facebookers or YouTubers?
There are some questions on there.
Are there? Okay.
If you want to go back after.
Yeah.
Answer them.
I just had a question for you. You're talking about the hypotensive patient,
Mhm.
your RSI dosing. What are your thoughts on lower doses? I know, at least on our protocols on the air, we typically advocate a lower dose for our induction agents and a higher dose for our paralytics. Is that something you would agree with or have comments on or thoughts?
I don't, because ideally, well, and this is something that we're going to look into, but ideally you want to use sedatives that are hemodynamically stable.
Sure.
Because it's not a very pleasant experience, even if you're lethargic. You have no idea what these patients are feeling or what kind of mental processing they're having. Paralyzing a patient and intubating them is probably one of the scariest things you can think about. So you want to give an adequate dose of sedative if possible, okay? And if you have a hemodynamically stable sedative to give, okay? Now if we're using something like Versed, obviously, yeah, we've got to do what's in the best interest of the patient. But we want to use, ideally, sedatives that aren't going to cause that. And ketamine and etomidate are pretty good as far as not causing significant drops in blood pressures and instability in hemodynamics. So, yes?
So question asked on Facebook Live. So we do not have Levofed. We have dopamine on the truck. So for the hypotensive patient.
Mm-hmm. So the question was, we don't have Levofed, we have dopamine on the trucks. Those are changes to come.
The
Yeah.
other one was, the only way to monitor CO2 is with the ET2 I-gel. We currently would have to figure a way out to cut to modify the CO2 detector so we can monitor CO2 in patients that are awake and breathing on their own.
So I don't think
That was just, we don't have the capability of measuring CO2.
Okay.
We don't have
As
the
far as-
nasal capnography.
We don't have nasal capnography.
Okay. But if you intubate them, then you can, but,
Yes.
Correct.
right.
It'll fit on the medium mass seal. It'll also fit on the CPAP mask.
Exactly.
Yes.
Fit on the CPAP and the medium. But it won't fit on the non-breather.
You can also just cut off the connector and stick the hose under another breather mask. I do that regularly.
So there we go. Multiple solutions. What else do we have? Anything else? Okay. Well, that concludes the session. I appreciate all of you coming, and we'll look forward to doing this next time.
Thank you, Doctor.
Mhm.